Good morning, everybody. Thanks very much. I think we should go ahead and get started. I am really excited to be here today to introduce my colleague, Yoni Buber, who will be talking to us about cardiopulmonary exercise testing. I think most everyone in the room knows Yoni by this point. He's been here for, how long has he been here now? Almost 3 years, 2 years, good. And has just brought a huge amount of progress to our program, not just in adult congenital heart disease, but I think in cardiology more broadly. Yoni got his medical degree from Ben Gurion University in Israel, and then did his training at Sheba Medical Center also in Israel. We nearly overlapped at the Boston Adult Congenital Heart Program, which is the ACHD fellowship offered through Boston Children's Hospital. And Yoni did a 2-year ACHD fellowship there, where he, during his second year, got extra training in electrophysiology with a really great group of pediatric electrophysiologists. After that, Yoni relocated to Columbus, Ohio, to do an interventional ACHD year with one of the legendary figures in pediatric interventional cardiology, Dr. Cheatham, where Yoni spent a lot of time doing both hemodynamic catheterizations as well as interventions like ASD closure, coarctation stenting, transcatheter valve implantation, and other such procedures. Following all that extensive training, he went back to Israel, where Yoni ran an ACHD program for about 3 years and had a very, very busy clinical practice in Israel, where he continued to do interventions and exercise testing. About 3 years ago, we bumped into each other at the ACC and started talking about finding a way to bring Yoni back to the United States. And Mike Landsberg, who may be a name familiar to some of you here in adult congenital heart disease, when I was speaking with him, Mike trained Yoni and me, looked at me and said, you know, Yoni is the best fellow I've trained. And I said, oh. So we were incredibly excited and honored to be able to get Yoni back. Yoni was actively recruited both by the Boston Children's Hospital Adult Congenital Heart Disease Program, by the Ohio State program, which is a world-class program. And I honestly think one of our greatest accomplishments as an ACHD program was managing to get Yoni to come and join us. I'm really thrilled by it. Yoni, since he's been here, has really made very important contributions. He started a pregnancy and heart disease clinic where we see pregnant patients in conjunction with, in the same room as the obstetricians, where we do combined visits with them, which is really quite important patient-centered way to approach things, especially for patients who are pregnant with heart disease who need to come for multiple visits over the course of several months. The ability to coordinate that, get it all done and coordinated with an echo was a great effort, and I think a real good contribution to our patients. Yoni, working with Lori Soini, has changed the way cardiopulmonary exercise tests are offered here at the University of Washington. There used to be a backlog of months with modest volume, and Yoni and Lori and others have really developed that so that the volume is more than doubled and the wait time is down to a day or two. And that's been a great contribution for all of our patients here who get cardiopulmonary exercise tests. You might think Yoni, given a grand rounds in a language that's not his native language, could be nervous here coming and speaking in front of a relatively new audience, but if you think that, you probably don't know his previous job prior to going to medical school, where he worked as a bomb diffuser for the Israeli army. So I would say that standing here in front of 50 friendly faces is probably not going to be the most stressful time in his career. His academic accomplishments are fantastic. He's a reviewer for multiple circulation journals. He's spoken nationally and internationally, helped run the ACHD board review course, has dozens of peer-reviewed papers. Today he's going to be talking about an interest of his, cardiopulmonary exercise testing. So it's my pleasure to have him here, and my honor to have him as a colleague. Thank you.
Wow, thank you very much. Very nice. Yeah, so I will be discussing cardiopulmonary exercise testing today. I have no disclosures for this talk. This is the outline. I'm going to go over the basics of exercise physiology throughout this presentation, not just in one stack of slides. I'm going to do this briefly, otherwise we would be here until Monday morning. And then the main part of this talk will evolve around parameters from CPETs that we report to you when you send your patients to get your CPETs done. Briefly go over about, on setting up CPETs, what we do in the Cardiopulmonary Exercise Test Lab. And then if I have time, I will go over the diagnostics and the prognostic implications of CPETs in mainly heart failure patients, also a little bit in congenital heart disease patients. And so this whole concept of incorporating exercise data, cardiovascular health, respiratory health data into our patients' assessment and follow-up plans has been gaining a lot of attention and became increasingly popular in medical literature over the past 35, 40 years, I would say. One of the first groups that looked into this was the group from the University of Pennsylvania in 1982. Carl Weber and his group showed that very elegantly, just by peak oxygen consumption, they were able to stratify their heart failure patients into severity groups. The next one came out in 1991, a really seminal paper by Donna Mancini and her group, showing that in their heart failure patients who were candidates for heart transplantation, just peak oxygen consumption was able to risk stratify their mortality, the mortality of their patients in 1 year, better than the left ventricular ejection fraction, better than the pulmonary capillary wedge pressures. And so these two publications drew a lot of attention and expanded the utility of CPETs into many other parameters and many other forms of heart diseases, including, I would say, first and foremost, our own congenital heart diseases. CPETs are just a part of our physical examination in the congenital heart disease world. Most of our patients would go and get CPETs, but also individuals with valvular heart disease, post-SAVR and more recently post-TAVR patients, patients with hypertrophic cardiomyopathy, and of course more data came out in patients with heart failure. And so exercise is a very compelling parameter to follow in our heart disease patients. Cardiac output, we know, increases during exercise from about 4 to 6 liters per minute to about 20 liters per minute in normal individuals, much higher than that in individuals who are well-trained athletes, lower than that in people with heart disease. At least at the beginning of exercise, that augmentation in cardiac output is due to the combination of the increase in stroke volume and heart rate. At some point, the heart rate just becomes too fast, and so diastolic chilling doesn't happen anymore, almost. And it is just the contribution of the increase in heart rates that augments the cardiac output at the second phase of exercise. But the increase in cardiac output is really only part of the picture of successful exercise performance. We need many systems to work in collaboration and in concert for exercise to be successful. We need good lungs to be able to breathe in the oxygen molecules. We need good vessels with good, meaning the red blood cells, with good affinity to oxygen, enough iron in them to be able to carry that oxygen that we breathe. We need the pumping chambers, of course. And very importantly, and this is a recurrent theme that I'm going to discuss in my talk, we need good exercising muscles that are able to extract the oxygen from the red blood cells and deliver it to the mitochondria to produce energy. And so when we report to you your patient's cardiopulmonary exercise test results, you will not see the terms cardiac output or ejection fraction in those reports. What you will see is that penguin with elephant's head called peak oxygen consumption, which is just much more than the cardiac output. But this is not just a random parameter that was picked to be reported in our CPET result reports. We know by Fick's principle, not Fick's formula, which is something a little different, but by Fick's principle, that there is a good correlation, almost a direct correlation between the peak oxygen consumption and the cardiac output. Basically, very basically, I would say Fick's principle states that the peak oxygen consumption equals to the difference between the arterial O2 content times the cardiac output, or just the amount of oxygen that is being delivered to the exercising muscles during exercise, and the venous O2 content times the cardiac output, or just the amount of oxygen that is being returned from the exercising muscles. When you shuffle those numbers around a little bit, this is what you get, the direct relationship between the cardiac output and the oxygen consumption, with the understanding that the difference between the arterial O2 and the venous O2 content during exercise gradually increases with each watt of power. Here are some numerical demonstrations of how numbers, I guess, look during exercise. In the denominators, you would see the peak oxygen or the oxygen consumption that is gradually increasing. And in the denominator, within the parentheses, that increasing gradient between the arterial and the venous contents of oxygen in the exercising muscles, and their correlation, I guess, between the peak oxygen consumption increase and the cardiac output. And this is finally the graphical display that we see in our exercise lab, increase in the oxygen consumption in the straight line. And in the dotted line, you will see the corresponding increase in CO2 production and the rapid decrease when the patients go into recovery. This is the graph that we see when we exercise our patients. One of the first groups that was able to describe this linear relationship very nicely between cardiac output and oxygen consumption is Bob Levine's group from Texas. And they did that while using invasive CPAPs. This is when we have patients sitting on the bike exercising with a Swan-Ganz catheter in their neck and an A-line in the radial arteries. And you can see that there's a good relationship shown here in the gray line in patients with normal heart function, as well in a little bit less, I would say, linear relationship, but also not bad in patients with heart diseases. Those patients were not heart failure patients per se, but patients with myocardial ischemia, but still a not bad relationship between cardiac output and oxygen consumption in invasive CPAP studies. Now, when we report the oxygen consumption to you, there are several ways that you will see those numbers reported in our CPAP reports. The first way that we demonstrate them is just by the absolute value, the absolute oxygen consumption as measured by the machine. The second one is the relative oxygen consumption indexed to the patient's weight. And then the third one is what we call the percent predicted peak oxygen consumption. And whenever we think of percent predicted values, I think it's important to understand where the reference values are derived from. In our lab, as well as in, I think, most of the labs in Western countries, it's certainly US and Canada, those numbers are derived from this study shown here below by Dr. Nader, published in 1999, the European Respiratory Journal. This is data that was obtained from 60 men and 60 women who were, I think, university workers in England, I want to say Oxford, basically showing that, men have slightly higher peak oxygen consumption values than women. This is due to many reasons, including higher muscle mass, higher red blood cell mass, and so on. And then there is a gradual decrease, very steady decrease of peak oxygen consumption over the years that kind of picks up towards the, I would say, early 60s or so, as you can see here. Very interestingly, as a side remark, that decrease in peak oxygen consumption over the years is not because of a decrease in stroke volume. Stroke volume actually doesn't change very much over the years. What does change is the heart rate response to exercise, and very interestingly, the ability of our muscles to extract oxygen. We're less able to do that, it turns out, over the years. And so individuals who keep training and keep exercising, even at later ages during their lives, 60s and 70s, usually maintain a somewhat higher peak oxygen consumption and exercise capacity as compared to those who don't. And that's the main reason, the muscle's ability to extract oxygen. Back to Dr. Nader's data. These are the reference values from the original paper. And I highlighted for you in the red boxes the BMIs of these patients, just because we use them as reference to our patients. The average BMI, I want to say, in that study was about 26.1 or 2 for males, 24 point something for females. And just by looking at our patients' data from the last month here in the CPAP lab, these are our numbers. So, the BMI for men was 29 or so, for women almost 28. And so my personal opinion is that it's important to look at those percent predicted values. I find them a little bit less predictable when we index them to patients' weights. And so, but if you go to the guidelines or to the recommendation paper of the American Heart and the European societies of how to interpret and how to risk stratify patients based on CPETs, this is what you'll see. You can use both the percent predicted values and the absolute values. And this is for patients with heart failure. And so anything that is above 20 is good. Anything that is below 10 is terrible. And the same concept for the percent predicted values. 100% is wonderful. Less than 50% is not so great. So CPETs are just so much more than oxygen consumption. And there are many more important clinical parameters that we will report to you on the reports than just the oxygen consumption. The first two parameters that I'd like to go over are the respiratory equivalent ratio, or the RER, and the anaerobic threshold, which are very similar. The concept behind them is very similar. They're calculated a little bit differently. As you may remember, the main source of energy during exercise is glycogen, being broken down to glucose, pyruvic acid, and then with sufficient oxygen, importantly, we produce, let's say, 36 molecules of ATP during that phase, with some CO2 and H2O production. However, there comes a phase in everyone's exercise during, even in the world's most well-trained marathon runner, where the oxygen supply to the exercising muscle is just not sufficient, and we switch to anaerobic glycolysis. At that phase, pyruvic acid is being broken down to lactic acid that needs to be buffered by HCO3 and potassium, and the amount of CO2 that is being produced is much higher than in the aerobic phase. And so this is a less efficient way to produce energy. There are only 3 molecules of ATP that are being produced here. This is the phase when we start to hyperventilate in order to breathe out all that CO2 that is being produced. And so the anaerobic threshold would be the point of exercise at which oxygen consumption, at which CO2 production, increases exponentially relative to oxygen consumption. That normally happens at about 45 to 70% of the peak oxygen consumption. This is the parameter that we look for, but it's not very specific. So decreased value could be seen in patients with heart disease just because of bad oxygen supply to the muscles because of a weaker pump, but also lung disease, anemia, understandably, there are not enough vessels to carry the oxygen, myopathies, and just deconditioning. Very elevated values are often seen in trained athletes. We just had a patient, or an individual who came in with unexplained dyspnea and exertion that was an elite athlete whose anaerobic threshold was almost 100% of the peak oxygen consumption. The other one, the RER, the respiratory equivalent ratio, again, very similar concept. Basically, it's calculated as the CO2 production divided by O2 consumption. At resting levels, that value is about 0.8 in all of us normally. And we use the RER to tell you that your patient did adequate effort during exercise. He produced, or they produced, enough CO2 to be ventilated out. And so a value that is higher than 1.1 would indicate adequate effort for us. Importantly, you need to see in our report that we calculated that parameter at peak exercise and not after or during recovery. Because during recovery, we breathe out, kind of ventilate out all the CO2 that was accumulated in the bones and the muscles in other organs. And so the RER keeps increasing during recovery, and we need to stop our calculation at peak exercise. The next clinically important parameter is the VE/VCO2 slope. Basically, this is the ratio between the minute ventilation, the VE, and the CO2 production. It's the amount of work we need to put into breathing in order to ventilate out the CO2 during exercise. I did not put that formula on the slide to annoy you at 7:50 in the morning. I just wanted to see that in the denominator, the highlighted numbers of the highlighted value in red includes the ratio between the dead space and the tidal ventilation. The whole concept behind dead space in exercise is an important one. As you know, when we sit here, about 30–40% of our blood vessels are closed. We don't use them at rest. However, when we exercise, the ability to recruit those blood vessels, to open them, implicates cardiovascular health. It's important that we will be able to open those blood vessels to accommodate the increase in the cardiac output during exercise. So that recruitment is healthy. In individuals who are unable to recruit those vessels, the dead space would not increase during exercise. I guess the best example for that would be patients with pulmonary hypertension. Other etiologies for an elevated VE/VCO2 slope would be heart failure patients. So in individuals with elevated LV/EDPs, they have backward congestion and mild congestion during exercise, which promotes hyperventilation. They try to breathe harder in order to ventilate out that CO2, and that increases the VE/VCO2 slope. Here is the graphical display of those slopes. On the right, you will see the normal graph. Normal values are below 30, and so the right graph is 23, which is normal, and the left graph is severely elevated VE/VCO2 slope, I would say, showing maldistribution, if you will, of the blood flow during exercise. You can't actually measure it, but we think that that's what it means. So the classic examples of patients with an elevated VE/VCO2 slopes would be patients with pulmonary hypertension. The next ones would be our Fontan patients, because they don't have a pumping chamber, and augmentation of the blood flow to the lungs is just more difficult. And then the elevated LV/EDP patients. In this very elegant study, I think published last year in heart failure, a group of investigators did invasive CPETs to 175 patients and looked into making a correlation between invasive hemodynamic data and just the CPET data that they get. The first observation that they made is that when they looked into a relationship between the cardiac output and the invasive wedge pressures, a ratio that was higher than 2 was associated with worse clinical outcomes at a follow-up of 6 years. And then the second phase was to kind of correlate that parameter, the CO divided by the pulmonary capillary wedge pressures, divided by the CO2, to non-invasive parameters. And the best correlation was found between the wedge pressures divided by the CO2 and the VE/VCO2 slope. And we like those studies because it indicates to us that we report values that have clinical significance, meaning that if we have invasive hemodynamic measurements that show us a correlation with non-invasive evaluation, we know that we're reporting something that is clinically relevant, I would say. And so when you go back to those recommendations from 2016, the American and European recommendations, risk stratification with the VE/VCO2 slope is also recommended. Normal values would, in heart failure patients, normal values would be below 30, and very high values would be above 45. The last clinical parameters that I'd like to discuss is the O2 pulse. I like this parameter very much. The whole concept behind the O2 pulse is that when you remember the components of the cardiac output, it's just stroke volume times heart rate. And when you want to evaluate what is the contribution of just the stroke volume to the cardiac output, you can divide the cardiac output by heart rate. And so we do the same thing. We take the peak oxygen consumption divided by the heart rate, and that would be the O2 pulse, which is a surrogate, we think, of the stroke volume. Here are 2 examples that would kind of highlight the importance of that parameter. Here's patient number 1. He was a young patient who came to the CPET lab for the evaluation of dyspnea on exertion and did not do very well in his stress test. His peak oxygen consumption was only 17.8, that's low. And his heart rate did not increase very well during exercise. He only reached 103 beats per minute at peak exercise, which was 64% predicted. And so when we did the math, when we took the peak oxygen consumption, divided it by the heart rate, we got an O2 pulse, again, a surrogate of the stroke volume that was normal, 102% predicted. And so we could pretty safely say that the main contributor to these patients' low oxygen consumption capacity was chronotropic incompetence. But here's patient number 2. She also reached only 17.8 mLs per minute per kilogram, but she responded well in terms of her heart rate response to exercise. She reached a peak heart rate of 144, and when we do the math, her stroke volume was low. So we think that the main contributor to her decreased oxygen consumption was just low stroke volume. And here are the graphical displays of 2 similar patients. This is what we see in the exercise lab. On the left here, you would see the increase in the peak oxygen consumption during exercise and the decrease when the patient goes into recovery. And here on the right, there are 2 graphs. The top one is the heart rate response during exercise, and this is the O2 pulse. So in this patient, the heart rate response to exercise was not great. So I would say moderate degree of chronotropic incompetence, reaching only 90 beats per minute at peak exercise, but a very nice increase in the stroke volume. So again, that patient would have chronotropic incompetence as a cause for his low oxygen consumption during exercise. This patient, on the other hand, much lower increase in the oxygen consumption, better heart rate response, reaching about 120, 120 something beats per minute at exercise, but a very flat looking stroke volume increase or O2 pulse increase looking graph. The appearance of the O2 pulse is also very important to us. Here's a patient, here's another patient with a good heart rate response, but a very kind of abrupt or acute increase in the stroke volume, but remains very, very flat in the remainder of the exercise. This is which indicates either myocardial ischemia, by the way, bad heart failure, or fixed obstruction to the flow from the LV, from the left ventricle. This patient indeed, this is one of our congenital heart disease patients who combines severe subaortic and aortic valve stenosis. So the appearance of that graph is also important to us. A few words on how we set up the CPETs. These are the screens that we see in our lab. On the left, you will see just the EKG, the blood pressure, the saturation, and so on. And on the right, the exercise parameters with the graphical display of the oxygen consumption and the CO2 production. The mask is not very bothersome to the patient, so I think that the bicycle seat is more difficult for them. It's just a hard seat that we need to work out. We have 2 exercise modalities that we offer to our patients. One is the which is the bicycle, and then the other one is the treadmill. Each has its pluses and its minuses, shown here on this slide. I would say that one of the important questions that we ask our patients is what they do for exercise. So if they walk or run, we would put them on a treadmill. If they bike, we will put them on the bike. My personal bias is a little bit towards the treadmill. It's important to note that peak oxygen consumption is 5 to 10% higher on the treadmill as compared to the bike, which makes sense. We just move more muscles. We walk as compared to when we bike. Another important population which I would put on the treadmill are patients with pacemakers. We just feel that the heel strike thing activates the rate response modality better than the bike. Otherwise, people have their own biases. I think you can get a little bit more or less noisy data on the bike as compared to the treadmill. The four most frequent questions that we're being asked when we get patients to be evaluated at the CPET lab are by far number 1, explain to us why this patient has this new or worsening dyspnea on exertion, because all of his clinical or her clinical parameters are stable. So that's the most common question that we get asked. And the second one is just risk stratification of patients who have advanced or severe heart or lung disease. The third most common question is to kind of evaluate what would be the best timing for valve intervention. We use that pretty commonly on our congenital heart disease patients, especially with the trial GFLO for pulmonary valve replacement. And then just evaluation after an intervention, after a valve replacement, after initiation of a pulmonary vasodilator in pulmonary hypertension patients, and so on. The workup of dyspnea on exertion in the CPET lab is something that I personally really like. I think it makes us think more deeply into the patients. The 2 most common etiologies for new or worsening dyspnea on exertion are heart disease and lung disease by far. And as you can see here on this slide, many of the parameters are very similar, so it's very difficult to tell them apart. Peak oxygen consumption can be reduced in both populations. The VE/VCO2 slope can be high in both populations. And so the first parameter that we look at is what we call the breathing reserve, which is the ratio between the minute ventilation during exercise and what we call the maximal voluntary ventilation, or the MVV, at rest. We pretty much ask the patients to take deep breaths for 12 seconds multiplied by 5 to get the number in a minute. And then normally all of us would be able to breathe more deeply at rest than at exercise, except for the heart disease patients. And so a difference that is higher than 30%, or a breathing reserve that is higher than 30%, between the breathing during exercise and the breathing at rest indicates healthy lungs. In patients with lung disease, that ratio would be lower than 30%. And so this is one of the parameters that we report to you, telling you your patient may have lung disease as a cause of his or her dyspnea on exertion. Similarly, anaerobic threshold is sometimes non-detectable in patients with lung disease. They just can't ventilate their CO2 out, so we're unable to diagnose where that anaerobic threshold is, and that is another clue that patient's cause for dyspnea is lung disease, not heart disease. Other etiologies for otherwise unexplained shortness of breath are what you see here. Patients who have shortness of breath with normal oxygen consumption would just be anxiety, can have anxiety. Early stages of obesity before they develop diastolic dysfunction, because then their VE/VCO2 slopes would be higher, and then just mild disease, mild lung disease, mild heart disease. A very interesting subpopulation of patients are the myopathy or the muscular disease patients. They would come in with dyspnea on exertion, pretty normal oxygen consumption, but very low anaerobic thresholds. They would switch to anaerobic metabolism much sooner, again, because their muscles are unable to extract the oxygen from the red blood cells. And so we would usually send those patients for invasive CPETs to measure lactates, to measure the AV gradient during exercise. And if that diagnosis is confirmed, we send them to neurology. This is a pretty cool diagnosis to make during exercise. We make it, maybe once a year or so. But when we do, we're happy. And then finally, the little time that I have left, I'm going to discuss the prognostic implication of CPETs in heart failure and congenital heart disease patients. And so going back to one of my earlier slides, all the systems that are involved in exercise can be impaired in patients with heart disease, obviously. Ventilation can be impaired because many of the patients have restrictive or obstructive lung disease. Pump failure, low cardiac output goes without saying. Many of the patients have iron deficiency or anemia. And then muscle wasting is a very, very important etiology in our heart disease patients for lower exercise capacity. Here's a nice graphical display of that, published 3 years ago, pretty much breaking down all the components of the peak oxygen consumption evaluation in heart failure patients, both with reduced and preserved ejection fraction. So on the top, you will see that these patients are able to augment their heart rate less well during exercise as compared to normals. They're able to increase their stroke volume less as compared to normal. And then look at the bottom panel here. Their ability to extract oxygen from the red blood cells is severely reduced as compared to normals. And all of this translates into much lower peak oxygen consumption in patients with HFrEF and HFpEF as compared to normal individuals. About 4 times higher as compared to 9 times higher in normal individuals. When we go into prognostic implications, the first study that was published, and I'm going back to my first slide here, is the study by Donna Mancini from 1991. There were 114 heart transplant candidates in that study. 35 were accepted for transplantation, 52 were considered too well for transplantation, then 27 were sick but were rejected for non-cardiac problems. And they show that the peak oxygen consumption shown here in the top panel was the strongest predictor for mortality at 1 year from many other parameters, better than left ventricular ejection fraction in the middle panel, better than the pulmonary capillary wedge pressures. And the parameters that they used was above 14 and below 10. That gave them the best discriminatory effects. However, if you've been awake for the past 30 minutes or so, you know that using just one parameter in CPETs is just wrong. I think they just did not have enough parameters to use at that study. And so there's been much more publications since then. And we know that using just this one parameter is just not correct in interpreting CPETs. And so more recent set of recommendation that was published 3 years ago or so incorporates much more data from the CPETs in order to adequately risk stratify heart failure patients. So if your patient has a peak oxygen consumption that is good, higher than 20, a VCO2 slope that is lower than 30, no exercise oscillatory ventilation pattern that goes up and down because of passive congestion as well, with the activation of central and peripheral receptors, and a normal anaerobic threshold, they have 1 year prognosis that is excellent of 95%. On the other side of the spectrum, 1 year mortality that is higher than 20% would be patients with low oxygen consumption, so below 14 or 12 if they're tolerating beta blockers. Their heart rate would just be slower, or less than 50% predicted in obese patients. They usually have somewhat higher oxygen consumption during their exercises. IV VCO2 slopes, they have oscillatory ventilation, and they have low anaerobic thresholds. Those are the sicker patients. And then in the middle would be the middle group, peak oxygen consumption between 14 and 20, still no oscillatory ventilation, and an anaerobic threshold, which is somewhere in there. I think things get more complicated when we look into how to incorporate CPET data into risk models that include other clinical parameters. I would say that Neil's poor statement here is very relevant. One of the groups that tried to do this is the MECI group investigators from Italy. They retrospectively looked at over 6,000 patients with heart failure who underwent CPETs. Average LVEF was 33. The peak oxygen consumption was low, 15 or so. The median follow-up was 3 years. So before that, the MECI risk model tries to incorporate oxygen consumption and the VCO2 slope with other parameters of heart failure, including the hemoglobin, sodium, LVEF, and the renal function calculated by the MDRD. And they claimed that their model is better than other models that include only oxygen consumption, and the Seattle heart failure model, which does not include CPET parameters at all. So 2 and 4 years cardiovascular outcomes, according to these investigators, were better predicted by their models and by models that do not include CPET data. I think that their option to retaliate was given to Wayne and Todd here, who astutely showed in their response paper or their editorial that this the MECI risk model is flawed. It's flawed because it does not include many parameters that are usually taken into account when we evaluate heart failure patients. Very importantly, beta blocker use was not included in that analysis, and as you can see in this nice graph that was added to that editorial, individuals with beta blockers just do better. The risk associated with the lower peak oxygen consumption is 50% lower for each ml per kilo per minute if the patient is on a beta blocker. Same thing goes for gender differences. They show that in HF action, women had better prognosis than men, and gender was not included in that risk model published by the Italians. And finally, I guess the final blow came in the fact that in an external validation study, the MECI model just overestimated cardiovascular death and transplant endpoints by over 20%. And so it's just, I feel it's just, we need more data on how to incorporate CPET parameters into risk stratification models. I think one of the approaches that make more sense to me is something that was published last year that pretty much tells us to look not at just this single window of time in our patient's life, just this one CPET, but to rather look at their trend. So repeat the test every 6 months in your patients and see what happens. So according to this, if your patient has an increase of more than 6% in the peak oxygen consumption, he's probably low to intermediate risk. If he has an increase of less than 6%, he's still an intermediate risk. And if their peak oxygen consumption decreases by more than 6%, he's probably a higher risk patient. You may want to start thinking about what to do with it. That approach makes more sense to me than just using a single CPET study to evaluate your patient's longer time risk. And then finally, prognostic implications in our congenital heart disease patients. I think one of the nicest studies that I would say ever came out in the world of congenital heart disease is this study from the Royal Brompton Group in London. Basically, they used over 2,000 patients with various forms of congenital heart diseases to create a database of patients in their peak oxygen consumption at exercise. So you can see here pretty much across the board of all types of congenital heart disease, ASDs, transpositions, Eisenmenger, you name it, it's there with reference values. So when I read CPETs of congenital heart disease patients, I try to use this rather than Dr. Nader's data that I used before. This is a graphical display of the peak oxygen consumption in those patients. You know, as expected, patients with simple lesions such as transposition who were repaired with an arterial switch did the best, and patients with Eisenmenger syndrome did the worst. This is very expected. As I mentioned before, one of the important implications, or one of the more frequent uses that we do for CPET in our congenital heart disease patients is to decide when would be a good time to replace a pulmonary valve in patients with tetralogy of Fallot. There is a bunch of data on that, and one of the important papers that came out from the Royal Brompton Group, showing that in patients with severe PI who had tetralogy of Fallot, peak oxygen consumption that was below 20 prior to surgery was predictive of early cardiovascular death or heart failure exacerbation after exercise. And so this study, as well as other studies, made their way to the recent guidelines that were published, in which we use exercise capacity as one of the parameters to assist us in the decision of the timing of pulmonary valve replacement in tetralogy of Fallot patients. And then in our Fontaine patients, data that came from the Mayo Clinic last year, showing that a gradual decrease in the peak oxygen consumption over the years was associated with higher cardiovascular deaths and adverse outcomes. And so to summarize, I would say that CPET is a wonderful test. It's capable of providing information on the function of the various systems involved in exercise. It's an important test to consider in the evaluation of your patients with unexplained dyspnea and various forms of heart diseases. It is importantly more than just an evaluation of the peak oxygen consumption. We can provide you so much more data than just the oxygen consumption. And the more data is gathered, the better is our understanding of our patient's pathophysiology. And then finally, as I showed, the incorporation of CPET data into long-term risk model outcomes requires further evaluation, and probably in the incorporation of more parameters than just the peak oxygen consumption in the VEV slope. Before I end, just some data on our CPET lab here. So Lori Soini invited me to join the CPET lab about a year ago, a little bit more than a year ago. And here are the numbers since then. We started with 1.5 days of having patients exercising our CPET lab, and we were up to 4 days of seeing cardiac patients and reading their studies. As you can see here in this graph, the number of patients with heart disease really increased from 7 per month, to about 31 patients per month now, and we can do much more than that. By the way, we have the capacity to accommodate over 70 patients, so keep referring your patients to us. Ongoing research projects that we do in the CPET lab include evaluating pregnant women for their exercise capacity, something that has yet to be described. The combination of CPET and echo is something that we start to look for in our patients with mainly pulmonary hypertension to evaluate RV-PA coupling. This is an interesting emerging field that was originated from England, and we try to incorporate that into the studies of our pulmonary hypertension patients, and then invasive CPETs, which are very interested and are being conducted by Peter Leary. Thank you to Lori Soini, who invited me to join the CPET lab here and have been teaching me and mentoring me for the past year or so. People from pulmonary, Rob Glennie, Robert Thomas, Peter Leary, who allowed me to enter the world of CPET here. It was kind of a pulmonary land before we came in. Elizabeth Bailey, who supervises many of our studies, and then Karen and Eric for allowing me to take a break from my ACHD responsibilities and see some patients at the CPET lab. Thank you very much.
Do we have any questions?
Yeah.
Have done very limited data to show this that they weren't that additive. So where do you see your role?
The best role would be for the evaluation of patients with unexplained dyspnea on exertion with low anaerobic threshold, I would say. And when these patients have, especially when they have very borderline blinding or non-invasive CPETs, you can actually quantify the AV differences during exercise, and you can get good lactate measurements in those patients. And so unexplained dyspnea on exertion would be probably the best example for these patients, especially when we think about muscular diseases or myopathies.
Excellent. There are a number of parameters that you're measuring. What can we do when we're ordering that to give you the information you need to decide what you're going to do with that, other than ordering a piece of that? The follow-up question: in the past, when I've done that, I've gotten nowhere near this level of detail. Was that actually reported, but just not reported? And can we go back and glean some additional information to assess, or is it on?
Yes, so let me start with the second question. We are in the process, I don't know if Steve Dolner is here, but hi. Steve's been helping us in collecting all the data, all the CPET data that was obtained here since 2007, and we are probably going to go back and look at those parameters. The parameters are there. They were just, as you say, not reported. I think that Lori and I, when we see our cardiology patients, we try to report all these parameters that I've shown in my talk today. I agree that the results were somewhat less informative previously. I tried to refine that for cardiology patients, heart failure patients, ACHD patients, and so on. And if we are being asked, we're going to go back, retrieve the data, and report on those parameters. If you're interested, we're going to go back and look retrospectively, do some retrospective studies on the correlation between heart failure severity and CPET data, between severity of Fontan circulation and CPET data. And we're going to try and retrieve all those parameters that were not reported, but are there. They're definitely there.
They actually went back and analyzed their data. I think they were already looking at the editorial, and they showed that I think we had around 7 to 20% for 5 and 20%.
Yes.
And so I would urge anybody wanting to use multivariable
I would agree with that, and I think what they showed, I didn't go into this because of time restraints, but What they showed is that over the years, that number, that magic number for you, kind of gradually decreased because of improved drug therapy and all those things. So I agree with that. Right. Short answer is that we don't know. We do know that for patients who have, for obese patients, their baseline oxygen consumption is much higher. There's some more parameters that I haven't showed, for example, that delta between the workloads and the increase in the oxygen consumption, that delta is much higher in obese patients because a lot of their energy is being spent by adipose tissue. I would say that we have reference values that are very limited for maybe 20, 30 patients that I personally don't use. I don't think anyone uses them, but they show that peak oxygen consumption are higher by about 10 to 15% in obese patients. What I do put in my reports when I see in obese patients is I put a little remark, and I know that Lori does that as well, is that the percent predicted values are not very accurate in that patient population. Again, that takes me back to the importance of just following your patient's data and follow-up studies. If your patient, don't look at your patient as this single window of time, but do a repeat study and see what the trend is. Those percent predicted values are much less well established for these patients, about 10 to 50% higher.
Yeah, I really love it. So you're clearly doing more tests is probably going to make you more quickly physicians happier and the hospital happier. But you did present some data showing that doing these tests, for example, to get a MECI score is probably not useful in patient care. So are there efforts to figure out whether increasing the test volume by threefold that's having an impact on patient outcomes?
Or follow-up studies, I think, yes. I know that many groups are looking into that. We're trying to get into those multi-center studies. There's certainly groups that look into that in congenital heart diseases. I know one group is looking into that in heart failure patients. That particular flow chart that I showed came from a group that looks actively into that, trying to come up with very strict numbers like that 6% increase that I showed for future risk prediction. So the answer is yes. We just don't know what those numbers are yet, but yes.
And clearly there's some suggestion that looking at that might be helpful in sort of but what about these undifferentiated patients? The first question would be, should that be useful in those patients? The second would be, do we need other parameters to assess? We get by so maybe nowadays the parameters could be coupled with the CPAT in order to give us a better idea of what's going on.
Yeah, I think that the answer is yes. I think that we just, Beth Brown, who's an exercise physiologist who works here, just got a very nice grant to look at that, and we're going to work together and look at RVK coupling and those parameters. So definitely RV strain will be one of the parameters that we are going to look at. Although in that specific study, it's just going to be patients with pulmonary hypertension, not unexplained dyspnea on exertion. An interesting concept, we can certainly try and look into that. The pay, by the way, is not very high for those. It's just the regular echo study and the regular CPET study. It's not considered that stress echo. And so I expect that we're going to do more and more of those combined CPET echo studies, maybe in conjunction with the invasive CPETs, maybe to replace them. And maybe just a common study to try and find correlation between invasive data and echocardiographic / CPET data. I think that's the future.